Hello, my name's Martin Cohen. I'm a psychiatrist and I work with an organisation called ProCare. This education series has been developed to support you, general practitioners, who are working in the front lines in providing vital mental health services to our community. This education series is partnered with our GP Psychiatry Support Line, which is dedicated to providing you with timely clinical advice in complex situations where you're unable to access a psychiatry review for one of your patients. My background is as a psychiatrist and an educator, and I'm currently Deputy Mental Health Commissioner for the New South Wales Mental Health Commission. Our organisation is very much focused on not only supporting our local community, but ensuring that GPs across the state who are enrolled in our GP Psychiatry Support Line are given appropriate and timely support in helping your patients receive timely mental health care. Well, welcome to this education session, and I'm here with David Burton, who's a consulting psychiatrist with ProCare. I'm very proud and honoured to introduce him today. First of all, what we'll be doing is we'll be cutting to a series of talks by David, and then we'll be returning to David and myself talking about those topics, and I'll be probing David as to developing a deeper understanding of what you GPs in primary care need to know in terms of the basics and the essentials when meeting people with ADHD, bipolar disorder, as well as gender dysphoria.
Hello, my name is Dr. David Burton. I'm a consultant psychiatrist in private practice in the Hunter region in New South Wales. Today I'd like to just talk a little bit briefly about adult ADHD, particularly for general practitioners. For many years it was thought that ADHD attenuated as people moved into adulthood. And for a percentage of people with the condition, this is certainly true. However, it's looking increasingly like symptoms are ongoing and in a decent percentage of people chronic and can lead to considerable distress. And often when ADHD is not picked up at an early age, and there can be many reasons for that. The client themselves becomes accustomed. They adapt to the way their brain works and do not feel they have a problem. Yet persistent, untreated ADHD is quite a potent precipitant and maintaining factor for depression, low self-esteem, anxiety, problems maintaining relationships, problems maintaining work. And it's not uncommon for a missed diagnosis of ADHD to wait to be revealed until an adult has presented for treatment for something else, like quite commonly depression. When people think of ADHD, they think hyperactivity, impulsivity, inattention. And each of these is on a spectrum. So people can have predominantly inattentive, milder impulsivity, milder hyperactivity, or any combination of these symptoms. We don't call it a disorder or something that needs assessment and treatment unless these symptoms are causing distress and impairment. And many people can have ADHD at school where there isn't significant distress and where there isn't significant impairment because of other things. And I guess one example there is when the individual has an above average intelligence. Other parts of their brain work well. They are dedicated, hardworking. They are supported by their parents. So even though this person may need to put in 4 times the amount of work to get the same mark that someone would get without ADHD and similar attributes, they still perform well. What happens then when this individual moves, like most of us do, into a job that's more sedentary, where there's much more of a focus on concentration, needing to listen, needing to follow instructions. And at the same time, you're settling down into a relationship where concentration, being able to listen to your partner, suddenly become very, very important. And long-standing chronic symptoms that weren't particularly bothersome, didn't particularly concern people, suddenly can cause marked distress, marked impairment. There is an incongruity between what the person knows is my internal potential, what I can actually do, what I'm capable of, and what they actually achieve. That incongruity over years is one, not the only, but perhaps one of the more powerful reasons that low self-esteem, lack of confidence in your own ability to do tasks that require cognitive work. And people often think, schoolwork, university work, but we need good concentration, good focus to maintain friendships, to maintain a meaningful relationship where our partner feels we're involved, that we listen, that we remember. We need it for work. We need it to drive. We need it for life. And when there are problems in this area, it makes sense that your self-esteem, your confidence is going to be eroded. That in itself is a risk factor for depression, anxiety, substance use, other problems. So it's quite common when you have a client presenting as an adult into your practice where the presenting complaint is low mood, anxiety, I cannot control my thoughts, stress, or just, emotional problems due to yet another failed relationship, another job dismissal. Ask about concentration, ask about focus, ask about ability to mentally relax. That should then lead to asking, do you still have these symptoms when your mood is good? Do you have these symptoms when the anxiety is not present? Were these present when you were at school? If we're looking at a longitudinal history of problems, then I think it is important and worthwhile to consider there is a comorbid diagnosis here of ADHD. And it's worthwhile in your formulation of the patient considering, has this played a role in precipitating, maintaining, or worsening the other mental health condition? To give you an example, generalized anxiety disorder, where there is at least a 6-month history of excessive worry, excessive concern over normal everyday things where you cannot control your mind. You cannot turn it off. You are going into catastrophic, worst case scenario outcomes. You add ADHD, someone where it's extremely difficult, even when they're well, for them to focus, give attention to detail. And you send someone with generalized anxiety disorder off, very appropriately and as per the clinical guidelines, to a psychologist for cognitive behavioral therapy, which involves homework, retention of information, new learning. The actual evidence-based treatment for these conditions becomes impossible or very, very challenging unless we treat the ADHD. When we look at research that looks at the incidence and prevalence of this condition, it looks somewhere between 5 to 10% of the adult population have this condition. Many of these will be undiagnosed, and we are increasingly seeing people in middle age and even late age presenting now for assessment. And there are many reasons for that. One will be the increased knowledge and mental health literacy in the general population, but probably the most common scenario I see is where parents or grandparents are attending the assessment for their child or grandchild. They hear what the symptoms are, they sit through the assessment, and the penny drops, and they think, wow, that's me. That's been me my whole life. Because we all adapt to how our brain works, and we get used to it, and we feel that's normal. And if it hasn't led to significant problems, then there's nothing to question. And so people can often discount symptoms of this condition and feel, that's just me. One thing that can make the assessment a lot easier is having a screening tool that you can give to the client or information that you can get them to look through at home. Adults often have a greater capacity for self-discipline and to inhibit, but the urge can still be there. It can be a lot more subtle. It can be avoidance of paying bills, avoidance of doing your tax, avoidance of keeping up with good healthcare. Making appointments is challenging, keeping appointments is challenging. Being able to think and structure into the future can be challenging. And it is so easy to reach the conclusion, I'm just lazy. I'm depressed. I can't turn off my mind. I cannot keep a relationship. I don't stick to anything. The presenting symptom they complain of to you may not be poor concentration, inattention, I can't sit still. It may be a consequence of the ADHD. And if there is clues that this may be a long-standing problem, give the client a screening tool that's validated. If this is suggestive as well, refer. And this does not mean that they need to go on pharmacotherapy. But having the diagnosis has other utility, even if it's just greater personal understanding, and for the person to be able to differentiate what they may have previously thought of was inadequacy, failure, laziness as symptoms of a disorder that's well recognized. The one final thing I will say before we finish with this topic is pharmacotherapy for this condition is generally highly effective, extremely safe, with few side effects. Unfortunately, there is a percentage of people that will not respond to treatment, and this includes the stimulants, dexamphetamine, methylphenidate, as well as the noradrenergic reuptake inhibitor, atomoxetine. For those people, there are other options that are best looked at by a psychiatrist, but it's worthwhile, if you are referring someone, to just keep their expectations realistic. Unfortunately, about 20% of people, the response to medication will be suboptimal. The good news is, though, the vast majority of people will respond highly favourably to a single agent and will generally notice global improvements in mental health. Not only suppression of the ADHD symptomatology, improved task completion, enriched, deeper relationships where they are able to listen, remember, and be more attentive. Improved self-esteem due to greater productivity, the sense of accomplishment that comes from that. You tend to get improvement in all aspects of mental health, functioning, and quality of life. And this is important, I think, to consider and underlies the important nature to look for this diagnosis, and if you suspect it, to refer to a specialist.
I thought perhaps first of all we'd start off by discussing adult ADHD, because this is an often vexed area in medicine, isn't it? Perhaps could you tell me about how a GP who's first confronted by a patient coming in telling them that they believe ADHD should engage that patient and what they should look for?
Certainly. And I guess that is becoming an increasingly common presentation for adults due to the raised literacy within the general community, but also adults who've lived for a long time are going along to appointments with their children and it's clicking, oh, I think I might have this. So even though a patient coming in and actually their presenting symptom is I am worried or I am concerned I have this condition is one way it can present, it's still worthwhile general practitioners keeping in mind that it can be the underlying, maybe not precipitating, but certainly a maintaining cause for a number of mental health conditions and presentations. Okay. But yeah, let's say a patient comes in, you take a history, you listen. You, in particular, try and be able to group what symptoms are being reported to you as symptoms of inattention, symptoms of hyperactivity, symptoms of impulsivity, and going through that differential in terms of questions with the client. If there is the suspicion, so there is no significant mood component, there is no significant anxiety, there's no other condition that would make you worried would be impacting on cognition. We have a number of tools, and general practitioners have a number of tools that they can use themselves to assist. And they range from the screening tools, quite simple, but also well-researched and validated.
But I thought you said something really interesting beforehand, which is that there may be behavioural manifestations in social, occupational or interpersonal functions, and they may actually be the primary driver of the presentation. Can you tell me more about that?
In psychiatry, there is a standard where we don't classify something as a disorder or as a problem unless there is distress and impairment. And so you can have problems with inattention, particularly if you're on the milder end of the spectrum, that may not be manifested in some contexts, but are manifested in others. And as adults, we get comfortable and used to how our brain works and we adapt. And so we can develop compensatory mechanisms that are highly effective. A compensatory mechanism that may keep you on task, allow accomplishment in a highly structured work scenario where there'd be very little distress, very little impairment. Same person at home, where the distraction, the inability to focus in the present moment leads them to drift away from conversations with their partner, their children. I think if someone is presenting and you have a recurring pattern that does not make sense, i.e. it's not due to a recurring mood, there's not an established maladaptive personality style, and it looks like it could be due to difficulties with staying present, being able to connect, not drifting away into lots and lots of different areas of your thinking, then ADHD should be considered in the differential.
I'm wondering, David, can you tell me a little bit about comorbidity in ADHD? Because oftentimes when people have struggled with relationships, they've struggled in their workplace function, substance abuse, anxiety and other problems may become a problem. Tell me about how a GP should approach understanding this and teasing this out in the context of ADHD.
We have this foundation of repeated mismatch between what you know you can do and what you achieve. And this often lays the foundation for low self-esteem. It lays the foundation for you losing confidence in your ability to stick with what you have said. People with ADHD will know, yep, I am capable of doing that diet. They don't stick to it. Then they beat themselves up. They see it as self-sabotage. They see themselves as lazy. They get criticised by other people. We then start to evolve a kind of inner dialogue and a cognitive structure around that that's based more along the lines of inadequacy, poor task completion, lowered expectation. Substance use is extremely common in any human condition where there is going to be chronic distress. In ADHD, there is also an underlying physiological drive towards impulsivity, recklessness, needing to move. So again, there'll be a complex relationship. It won't be a simple unidirectional, but there is going to be a strong correlation between ADHD, mental illness, ADHD, substance use disorders, and other social and functional and behavioural problems.
From a physiological basis, it makes sense, doesn't it? That comorbidity in terms of certainly impulse control disorders, addiction, anxiety disorders, but also if you experience long-term interpersonal and occupational adversity and feel as though you're unable to achieve what you believe you can achieve, that depression might be a likely comorbidity. If we look at the learned hypothesis of depression, We understand that being stuck in a situation when you're unable to retrieve yourself, to extricate yourself, that's when the prefrontal cortex shuts down and depression becomes likely. So thank you for that. I guess I'm wondering, what recommendations would you give to a general practitioner who's seeking to refer you a patient with ADHD? What would you like to see done before a patient comes to see you?
I think it's always really helpful when a referral is coming into a specialist that there is the basics, a list of medications, but also, I guess in particular, what I look for is a bit of a longitudinal history. It can be very, very simple. These symptoms have been present since childhood. A bit of a comment on what is the meaningful, I guess, experience for the client. The client is worried, wants this treated. And it'll be different for different people with ADHD. It's really, really helpful if there is even a very, very simplistic psychiatric history. So you know, going into your assessment as a specialist, there is also the presence of depression, or there is also the presence of anxiety or a substance use.
And so in terms of physiological workup, is there anything that you require before somebody's referred to you for an ADHD assessment, David?
Not in particular, no. I mean, obviously, if there is something in the history that is worthwhile for me to know about that's separate, certainly, but no. ADHD, there is no need for any kind of investigations prior to referral to a specialist.
Okay.
Detecting bipolar disorder. We know from overwhelming research that bipolar disorder, the rates of detection are poor. It is common for people with bipolar disorder to be initially diagnosed with major depression and to be treated with an antidepressant. When we look at the available evidence, people that have a diagnosis of major depression, and particularly people that have a diagnosis of treatment-resistant major depression, when they are reassessed, up to 50% in some studies have bipolar disorder. The treatment for bipolar disorder is very different to the treatment for unipolar depression. And we know that early treatment, suppression of symptoms, return to functionality are tightly correlated with prognosis and quality of life. Some studies have suggested that it can be on average up to 10 years and an average of 4 individual mental health experts reviewing you before the majority of people get a diagnosis. And there are many reasons for this. One reason, for example, is that patients often have very poor insight into a hypomanic episode or an episode of elevated mood that may not reach DSM categorical criteria. They will often, it's rare for patients to report these times as being issues or problematic. So it's important that we search for them in the history. One reason, but certainly not the only reason, that the detection rate is poor is because these symptoms are not asked at the index, the initial assessment. And it's really common in a health system where it's busy, high demand, poor resources, that the original diagnosis is accepted and run with. Why is it important that we get a diagnosis early? For many years, the depression in bipolar was thought to be very similar to the depression in unipolar. So much so that even the latest DSM, DSM-5, uses the exact same criteria to diagnose. There has been much discussion, opinion, and in recent years, increasing evidence that a dimensional rather than a categorical view of diagnosis and symptoms is more helpful. And there is a growing awareness that bipolar itself is a spectrum disorder. The categorical symptoms in DSM can therefore miss the milder forms. When we look at the rates of severe impairment, there are similar levels between people with bipolar 1, bipolar 2, and people that have a bipolar spectral disorder or a syndrome of symptoms that does not meet criteria for DSM. Their distress is similar. The impact on employment, relationships, similar. Some studies have suggested that the milder forms of bipolar, and in particular bipolar 2, have a greater morbidity than bipolar 1. So it's really important that we look for and detect this disorder early. The treatment for unipolar depression, which is monotherapy with an antidepressant plus or minus lifestyle plus or minus psychological intervention, has been demonstrated to be, in large groups of people in well-designed studies, non-effective in bipolar depression and possibly harmful. Yet most people with bipolar, their index episode will be depression, and this is the treatment that they will begin on. It is common for partial, incomplete response, ongoing symptoms, ongoing problems, ongoing impairment, decreasing self-esteem, decreasing social connectiveness, decreasing competency. And bipolar hits during adolescence and early adulthood, the time when we do an enormous amount of growth. Social learning, occupational learning, educational learning, relationship learning. And if it's not treated well and it's not treated early, this stage can be disrupted due to ongoing distress, impairment in the person, which of course can lead to other conditions that may not be amenable to pharmacotherapy or time-limited psychology. The relationship between bipolar disorder and other comorbidities in mental health or substance use disorders is likely to be complex. It's not going to be a simple causative pathway. But what makes common sense is if we get early control of bipolar, we will likely reduce the risk of developing other problems. When we look at bipolar 1 and bipolar 2, around about 3/4 of people will have a minimum of 3 other psychiatric diagnoses. When we look at people with sub-threshold bipolar spectral disorder, over 50% will have a minimum of 3 other comorbidities. And I think this speaks very strongly for the need to detect early and treat early. So how do we do this when someone is presenting with depression as their main complaint and there doesn't appear to be a clear, ostensible history of hypomania or mania? Some of the ways that may be helpful. There looks to be some evidence that bipolar disorder is very closely associated with anxiety. When we look at adults with bipolar, we are looking at 62% of them meeting criteria for a formal diagnosis of an anxiety disorder. 50% of people with bipolar will have had problems with panic attacks. There is some evidence that the first clinical presentation of this disorder is anxiety in childhood. Again, these are not diagnostic signs. These are just suggestions, and the literature is still evolving. But bipolar disorder appears to be more closely associated on that first presentation, which is typically depression, with more severe anhedonic depression. Depression that may have a more abrupt onset, is associated with a diurnal mood variation and hypersomnia. It's more likely to have unusual presentations, catatonia, psychosis. So how do we improve our ability to detect bipolar when the patient is only reporting episodes of depression and they're in the early stages of their mood disorder? Sometimes patients will not have good insight into these hypermanic periods. Sometimes patients will not experience the euphoric, driven mood, which DSM puts an enormous value on. If we look at the clinical research that some research is suggesting may raise the suspicion that someone that is presenting with an episode of depression may actually have bipolar are depressive episodes that have a much more sudden onset. Episodes where there is intense anhedonia. Episodes where there are more unusual presentations. Psychotic symptoms. Catatonic symptoms. Obviously, if there is any suggestion of mixed symptomatology, which can sometimes be mistaken for depression with associated anxious distress, when it may actually be the drivenness from a concurrent manic process or hypomanic process. There is some suggestion that in bipolar disorder, it is more common than in unipolar depression for people to meet full criteria for a depressive episode, but that they are short, 2-3 days, alongside their longer episodes of depression. What is helpful in terms of doing an assessment and taking a history? I believe, and this is my opinion, that it is often more helpful to be knowledgeable of the more subtle signs of mania that are present almost uniformly, whether it's a manic episode, a hypomanic episode, or an episode that current opinion is looking at, a bipolar spectral episode. So one that doesn't meet full criteria for a hypomanic episode. One resource here that is very, very helpful is the questionnaire on the Australian Black Dog website. You will see there, when you look at the questionnaire, there is more emphasis given to increased self-esteem, increased sense of connection, increased creativity, rather than a driven, elevated, expansive, euphoric mood. This is a simple questionnaire that can be given to the clients or something that you can incorporate into your history taking. One point where the research is very clear in that should raise suspicion, and of course this makes common sense, is a family history. It's easy to forget things like family history when you're dealing with a patient who is profoundly depressed, very distressed, and you have limited time. But having a structure where you have a high suspicion for bipolar, for people that are presenting with depression, and where you have a structure to look for evidence for bipolar in the history should be part of any standard mental health assessment.
I'd now like to turn our attention to bipolar disorder and the bipolar disorders. Personally, one of the most satisfying things I can do clinically is actually help somebody understand that those brief periods of mood elevation actually mean something, and the cyclic nature of them actually mean something. And one of the most rewarding experiences I have is when a person experiences mood stabilization and they experience a significant change in their cognitive functioning, in their interpersonal functioning, and they experience stable mood. Tell me about your experiences and your thoughts in this area.
Well, it's interesting listening to you say that. I fully agree that that is often the end final positive outcome. A lot of clients grieve for the loss of the mania in the short term. And I think that's a very common ubiquitous experience, and I'm sure a lot of general practitioners will hear that after a client has been well treated in the very early stages from us. I miss the highs. But you're right. And I've had clients where they have had years and years of misery. Partial or poor response to antidepressant therapy. And you take the history and brief periods where the self-esteem inflates. And I think one of the core symptoms that is worth communicating is because when a patient has a long-standing history of anxiety and low self-esteem and it fully resolves, it goes. I've always found that very telling. And there are these milder episodes when you point out to a client, and as you were talking about, that this is actually a symptom, and it's a worrying symptom. It's a symptom that you have a vastly more serious illness than depression. And then you treat them. And that chronic subsyndromal anxiety, that subsyndromal dysthymia that they have gotten used to, seen now as possibly a permanent state, resolves. And they return to having really good mental health after many, many years and often multiple medication trials. And yes, I would agree. It is one of many very satisfying things about the job.
Yeah. Breaking a diagnosis and discussing with somebody that actually, no, you aren't somebody who just doesn't respond to antidepressant medications, but you do have a problem that is significant and serious, can be challenging in any context. Do you have any specific advice for general practitioners who are negotiating that conversation early on when they might have an inkling that other person needs to be referred for further assessment?
I think the first step is to seek agreement with the client collaboratively on where the areas of distress first are, and then good psychoeducation. People like to be informed about what's going on. They like to know what the available research and treatment is. Looking at it very simply, one would imagine that someone would prefer to just have depression, and that there would be difficulties and maybe even some challenges discussing with the client that, no, you have bipolar. People want their distress gone. They want to get control back of their lives, and accurate diagnosis is mandatory for accurate treatment. And sometimes there can be challenges and difficulty in the early stages, but I think if the general practitioner returns to, let's have a shared aim of getting you really well. Let's have a shared aim of getting your confidence back, your functionality back. And I believe the pathway to that is that we consider you may have bipolar rather, and we look at a trial of a mood stabilizer.
I think you raised the point there of accurate diagnosis, but I think also I reflect back to one of the US early studies where they looked at the average time to diagnosis of bipolar disorder. What are your thoughts on time to diagnosis?
It's still very high. Even more recent studies are showing upwards of 10 years still in some demographics, going through a minimum of 3 to 4 mental health professionals. There are many, many reasons for why diagnosing this is a challenge. And they're not all due to a deficient history. Patients' level of insight, patients' level of comfort in disclosing changes over time. Being able to accept and therefore communicate what's going inside of you is a process. And the general practitioner, who is the very first doctor that patient sees, may be just starting that process for the client. And if the client does not recognize these periods as being abnormal, unhelpful, or pathological, they might not be disingenuous, but you may still not get an accurate history from them. So I think there needs to be an acceptance and an understanding that this is still a challenging condition to diagnose early. We are getting some guidance not diagnostic but suggestive from the literature, that there are differences in the symptom profiles for bipolar depression and unipolar depression, and it's worthwhile knowing what the research is coming up with. It's also coming up with hints on, particularly around childhood and anxiety and comorbid anxiety, that may be more suggestive. If you take a thorough history, if you include looking at hypomania and mania, but also include in that the sub-syndromal symptoms that are not in DSM. But when you look at well-researched studies, when you speak to experts in the field, they will mention these symptoms are very, very reflective, such as increased sensory sensitivity, vivid colours, sounds, smells. Yet, when we look at the research, this is a very, very common symptom. I mean, history, literature, philosophy have linked this disorder with creativity. It's not in any of the DSM categorical symptoms. Yet it is in almost every episode, even if euphoria is not. Even if driven physical energy is not a constant. That increased sense of understanding, I make sense, life makes sense, I'm so creative, I could do things. These are the kind of core features. And one resource that I would recommend is the questionnaire on the Australian website, the Black Dog. And I think there is a reason why in that questionnaire you will not find euphoric mood, but you will find these softer symptoms that are reflective, suggestive, and worrying that there is a mood episode occurring that has gone undetected.
In search of early diagnosis.
Absolutely, yeah.
I mean, when I think about the presenting symptoms within the context of a depressive episode, I often look for unusual responses to antidepressants, a sense of emotional blunting on antidepressants or agitation, depression before the age of 25, increased appetite, hypersomnia, excessive guilt, presence of soft psychotic signs, as well as increased speech latencies. And when you look in the history of somebody who has been through several mental health professionals and not received treatment that ameliorates their depression, oftentimes you'll find those symptoms and the sudden onset of the depression.
Yes.
Another key feature, and the good inter-episode functioning, although episodes can take some time to resolve, but those are suggestive that you need to really look at the softer signs in the mood elevation spectrum, don't they? Yeah.
I wanted just to talk very briefly about gender dysphoria. It is a diagnosis that has become increasingly prevalent in the media, and we are getting increasing numbers of people presenting for assessment, treatment for the condition. At its core, gender dysphoria is where the assigned gender at birth does not match with the patient's experienced, lived, authentic gender identity. This malalignment leads to distress, and there are many, many reasons for that. It is common for people in primary care to face challenges and to lack confidence in dealing with a group of people and a condition where you may not have studied it at med school and received training. And some of the guidelines that are coming out are helpful, but also have problems. The diagnostic criteria in DSM is in the process of changing, and it's pleasing to see that it has changed in the latest edition from gender identity disorder to gender dysphoria, where that change reflects the considered opinion that this is not a mental illness. It never was a mental illness. It is a part of human experience that unfortunately at this point in time causes a lot of distress, but very fortunately We have ever-expanding technology and treatment. When someone with gender dysphoria presents, it's important to, and this may sound like common sense, but it's actually worth stressing, it's important to treat them like any other client. There can be a multitude of reasons why someone with gender dysphoria may present, and it may not be for the gender dysphoria. It may be for other health complaints. If you do have a client that is presenting and wants to seek guidance, input, assessment, diagnosis, most of the guidelines put a lot of emphasis on getting a shared communication quickly, where you clarify what their new name is, what pronouns they are comfortable with. This information is really important, but it can also be unhelpful to go immediately into an interrogation where you are placing someone who may still be very confused, who may still be battling with where they lie on the spectrum of gender. It's often more helpful, in my experience, to simply listen, have the client tell you what they are experiencing, and then get a history of what they present with. Almost every single person will have the experience of discomfort, distress with their assigned gender and the physical phenotype of their body. And it's very useful and helpful to get how long, how severe was the distress. Particularly look around puberty when the secondary sexual characteristics are developing. It's more useful here to be empathic, exploratory, and open-ended with your history taking. Ask the person, where do you feel you are on the spectrum? Validate their experiences. People are complex. Not everyone will identify as I am female, I am male. It is going to be common to have people that are confused. Reaching acceptance and a consolidation around gender identity is a process. Often the best thing is just to be kind and to listen and to link the person with support services. When the individual has a clear sense or a growing sense of this is who I am, then it is very helpful at that stage to clarify the semantics around shared communication, such as how would you like to be addressed? How comfortable, what pronouns would you use, rather than right at the beginning. There has been for a long time a sense that if there was gender dysphoria with other severe mental illness, that perhaps these people do not qualify for treatment. Perhaps we should look at stabilising other areas. This is not a view I share. The evidence is overwhelming that treatment with hormone replacement therapy, treatment with gender affirmation surgery leads to improved mental health, improved global functioning. The other issue that I think is worth exploring, though, is that comorbidity is very high. Up to 60% of people with gender dysphoria will have a diagnosis of major depression. Up to 40 or 50% will have a diagnosis of an anxiety disorder. So it is important to look for comorbidity. And as long as that is being looked at and there is a treatment plan, progression through transition treatment should still be considered. When people with gender dysphoria come to a general practitioner, it's unfortunate, but it is a feature that there is often a history of discrimination, vilification, at times abuse, and at times more severe treatment. In some cases, you may be the first person they are talking to. And it's really important that that first assessment is one where they feel safe. where they feel heard, where they feel understood. In my opinion, that's more important than rushing into discussing hormones, getting the referral to the psychiatrist, getting the referral to the endocrinologist, getting a good therapeutic alliance where a person who may be fragile, may have comorbidities, may have been mistreated, feels like I am now being heard. I now have a voice. There is now a pathway where I can become my authentic self is so important. And yet, I think it's very, very common for general practitioners and psychiatrists, all of us, to have a level of self-doubt about our skill, our ability, when we're dealing with people that have been marginalized and when we're dealing with a condition that we may not have a high level of expertise in. My advice is you start from a base of diversity. You start from a base of assuming nothing. And your aim is the same aim that you have with everyone, that you have spent years learning to be very good at. And that is simply being kind, empathic, and helpful. Many people are worried or have concerns that they will cause offense. They'll do something that is unhelpful. I feel a better approach here than having concern or worry is to simply accept there are going to be therapeutic disruptions. There are going to be people with this condition that do find certain terms upsetting, misuse of a pronoun, misuse of a name, upsetting, that may find a certain attitude upsetting where there is no intent. It's going to happen. Accept it. Have a plan for what to do. So if it should happen, you treat it with humor. You identify it quickly as a problem. You seek collaboration. How do we solve this? What did I do wrong? What was the effect? I'm really sorry. What can I do differently? And move on. There is also often concern about, could this person not have gender dysphoria and they're about to start treatment that has irreversible effects. They're about to start treatment that could lead to infertility. They're about to go on a pathway which may lead to drastic remodeling of their body. These are sensible and reasonable concerns. They don't need to be looked at in the beginning. What's important is to form a relationship of trust and safety. And these issues can be looked at by a specialist at a later time. It's not your job or your role to give a diagnosis and to start treatment. This is done at a specialist level. But I think it's important for general practitioners to feel confident in their already well-established abilities that you then apply to an area in a disorder where you might not feel super confident. Taking it slow, seeking consent for questions, clarifying, giving validation, giving praise, and giving a direction where good care can be accessed, letting them know that you will be there for what will likely be a long journey. These are the priorities when you first meet someone with gender dysphoria. It is worthwhile having some knowledge about the transitioning process and what it involves so that it goes smoothly. It is also worthwhile being aware of the unique physical health problems of this community. Just as an example here, people that are assigned male sex at birth who have now had over 10 years on female hormones have a risk of breast cancer. They need to be taught how to examine their breasts. They still have a risk of prostate cancer. It's very low, much lower than it is for men who are not on hormone treatment. As they age and along the lifespan, their health needs are different. This person is about to go on a very dramatic change in terms of their physiology, their hormone profile, their self-esteem, how they view themselves, how society views them. They're going to need support. Getting their lifestyle healthy is going to be extremely important and may not be looked at by the specialists that are treating them. And this is one area where you, as the general practitioner, can improve their prognosis, improve their resilience, and play an important role in their journey.
So if we could turn our attention now to talking about gender dysphoria, because this is an area that really has not been well understood, not been a sophisticated part of medical training, nor psychiatric training, really. Tell me about how you would educate me, who is somebody who hasn't had a large breadth of experience in working with people with gender dysphoria. How do I engage somebody? How do I work with somebody who's presenting with those issues?
You treat someone with gender dysphoria exactly the same that you would treat anybody else. Empathy, exploration, ensuring they feel heard, understood, and that you are able to provide them with some direction towards relief. And I get feedback in terms of anxiety and sometimes doubt, where I don't feel as confident, I don't feel as secure in dealing with this group. People should feel comfortable that they don't need to worry about having every answer. It's okay as a general practitioner to go, I'd really like to help you. I know someone who is an expert here. Would you feel comfortable if I spoke to them or referred you? But there are very few problems where you cannot help, or at least start the process.
So I think you touch on a very important point there, which is that in the very busy practice of a general practitioner, where people are coming through for multiple short appointments, that if somebody is presenting with a gender dysphoria issue, should they feel comfortable booking them in for several short appointments or creating a long appointment, bring a person back, develop a rapport? And what specifically should the general practitioner look at in terms of their own feelings when they're presented with a patient with gender dysphoria?
So starting off with building a relationship, listening to what the patient sees as their priority, and responding appropriately. If the issue is, I am confused about my gender, you validate. You allow them to ventilate. You reframe stuff that is critical or toxic or unhelpful. You seek an agreement that, yes, this is a problem, this is distressing. Let's refer you to someone. And it's really important. One thing I want to stress here, they need to be a trained expert. There are a lot of people offering counselling to various people. We need someone who works with evidence-based treatment. If there is going to be a delay, and so this person is going to be holding on to distress, then in that situation, if you have the capacity, certainly offer them appointments and build up a relationship. All of the physical health problems that affect an individual who is in a male body, and all of the health problems that affect an individual who is in a female body due to sex hormones can be doubled. You will get both. And so you are going to have this patient as a client for a very long time, well beyond the time that transitioning treatment is an issue. Well beyond the confusion around gender and how do I consolidate a new gender identity is an issue.
That really speaks to the fact that you should always treat the problem in front of you. And it's easy for people who perhaps haven't worked with transgender populations to become anxious. And so to launch straight into defining pronouns and defining and creating boundaries and parameters so that they feel like they're not offending a person. But really, from what you've said, deal with the problem in front of you, engage the person, use your empathy, and work with the problem.
One, not the only, and in sometimes not the major cause of the dysphoria, the distress in this condition, is being forced into a category or labelled with a term that does not resonate with their authentic, genuine self. Everyone gets taught 101 year one, open-ended questions, gentle exploration, and follow what the patient says.